I think we're going to go ahead and get started. Good morning, everyone. Welcome to our first ECHO for Integrating Behavioral Health in Primary Care. This is our QI ECHO. This is session number 1. Very excited to have you all here. Happy that you've all joined us. And what I want to do is just really quickly show you, we have a data use notification, and you've seen this before in the documents that I've shared with you. For the ECHO project, really, they want to be able to collect participation data. So who's participating, where are you? That is what they are collecting, and that's what we report to them. So that's why we do attendance. We also share with them kind of what our didactic information has been, a high level about the case presentation and the recommendations. So this is kind of that data use notification that you will see every time that we get together, just to remind you all that we will be sharing this data echo. Also, I've got up here Zoom session etiquette, log in early, join with video. Seeing each other is part of the magic of connecting and networking. So we really want to do that. And if you're not speaking, we ask you to go ahead and mute yourself, because little movement of paper and noise that you have in your area will come through very loudly to others on the session. So, and then for attendance, we always ask you to go ahead and put your name, organization, and email in the chat box. And we ask you to avoid multitasking and to be present with us for the hour that we're together. Please use the chat box to ask for help or to ask a question. And when talking, look into your camera, which is super, super hard for me. So I will try to be very focused on this thing on the wall in front of me, but it's a little distracting. I'll just call that out. So all of your functions, audio is a big one. You can only sign on with either phone or computer audio, or you get a really bad sound that hurts your ears. So choose one. And then we also give you instructions on how to make sure that your sound works. So all of the slides that we talk about today will be shared with you after the session, as well as if any documents, articles, etc. are referenced, we will pull those and send them to you as well. So fear not, you will have them after the fact. Just what this Zoom thing looks like, so you can kind of see where you unmute and start the video, where the chat is, let you know some functional information. And then that's what the chat looks like. You can chat to everyone or just to ICSI itself, just to know that you can change that delivery method if you need to. So welcome. Who is on our ECHO? Well, these are the ECHO organizations. So when I look at this, you can see that I have what's called Core Hub Subject Matter Experts. Those are the organizations that have been participating in the Minnesota Health Collaborative for the last couple years with integrated behavioral health. The body of work that we're going to talk about that they'll share with Didactic is the community standard that they have adopted for integrating fully into primary care behavioral health. So you can see we have Allina Health, Children's Minnesota, Hennepin Healthcare, M Health Fairview, North Memorial Health, and Sanford Health. So I will refer to them as Hub Subject Matter Experts, and that is ECHO terminology. Also, we have our spoke or learner organizations. Now, the spoke is also ECHO terminology, and we have Community Health Services, Inc., Entire Family Clinics, Fairview Mesaba Clinic, Hibbing, Lake Superior Community Health Services, Open Door Health Center, and Ortonville Area Health Services. So these are our folks that will be participating in our ECHO. And as I talk about this, we will also occasionally have some observers that will come in. And when I talk about what an observer is we may have others from outside of our ECHO that want to come in and kind of learn about ECHO and observe how the process works and gain an understanding of how this flows. So we will have our Core Hub experts, we will have our spoke learner organizations, and we may have observers from time to time. As we get started, what you can expect today is from an anatomy of an ECHO, we have our welcome and our intro where I've asked you to do your sign in so I know who's playing along with us and who's in sharing today for networking. And then also I will ask for the didactic education will come next. And that will be done by one of the core hub subject matter expert organizations. And after that, we will move into the case presentation by one of our spoke learner organizations. We will have discussion about that and recommendations, and then we will wrap up the session for the day. So that's kind of the high level overview, just to kind of let you know what to expect. So today, what I'm going to do is I'm going to move us into our didactic piece, and we are very happy to welcome North Memorial Health this morning, and Jessica Castor is going to go ahead and present for them. And with the integrated behavioral health into primary care cross-model IBH framework, the principle that they're going to focus on their sharing today is patient-centric care. And during the presentation, we will show you the principles of the cross model that I have shared with you previously, but just as a reminder. So Jessica, welcome, and it's your turn. So you can go ahead and unmute yourself, and
okay.
Happy to have you join us.
Great, thank you. Are you able to hear me?
Yes.
Okay, so that's good. All right, yes, so no disclosures. Good morning, everyone. Thank you for letting us present for you or with you today. We're just here to learn as well. This is a big learning process for all of us, I think. So yeah, we wanted to focus on the patient-centric care because that really does fit with the overall mission of North Memorial, and I think the IBH process just fits that beautifully. I'm always like, yeah, we're right there with you. So having that patient-centered care piece is, critical at multiple levels at our organization. So I thought that would be a good place. We thought that'd be a good place to start today.
Okay.
And the way I broke this down was just into two parts, kind of what we're doing currently and things we continue to think about and talk about and would like to continue to develop as we, move forward here. All right, and real quick overview, focus on staff. I wanted to look at what we're doing for staffing, our evaluation process, how we do warm handoffs and curbside consultations as sort of our initial introduction to meeting with folks, patients, and then how we do a little bit of a risk assessment function and referral service function. So those are broken down a little bit more. So we are currently very excited to have added our fourth team member. She's just starting, this is her second day officially with us. So that's very good. So now we have 4 primary care clinics that have full-time coverage from behavioral health. And I know a lot of places, and I was doing this too for a while, covering 2 different clinics, that's great. Some places have maybe one person once a week or something, or one day a week or something that they can come and have behavioral health presence, which is great, better than not. But I find it really helpful that if we're there full time, then we really can do warm handoffs and be available when people are in the need, in that moment of, hey, this might work, and they have a few minutes to talk with us. So we're trying really hard to, offer that availability. And we have been creating some, updating and new marketing materials for our new PCPs. We've had a lot of turnover in a couple of our clinics, so we're trying to do some education and introductions to who we are to the new supervisors in our clinics as well as our primary care providers, and then also, for new behavioral health folks who come on as well. It's very helpful to just kind of make sure everybody's thinking the same sort of way, and we're using it during our onboarding. So screening methods we're using, kind of following the guide of DHS, using PHQ-9, G87, HUDAS, and CAGE. Those are kind of the primary ones. Sometimes we'll add a mood disorders questionnaire if the primary care doctor has that as their question, which I find to be often the case. Hey, this person is, having some symptoms, and I'm thinking about prescribing an antidepressant, but I don't know if they have a bipolar kind of depression, so I want to be mindful of that. So they often want a little bit more information, more specific, evaluation for that mood disorder kind of stuff. And then I've personally started using the insomnia questionnaire. It just seems to come up a lot, and it's kind of a nice way to get people to talk about their sleep issues. Seems to be kind of a primary issue in primary care. If y'all probably have noticed that or have that issue come across your desk. And then, so that's at the initial intake. And then as people come in for follow-up sessions, we usually do the PHQ-9 and the GAD-7 only, you know, just to kind of keep it streamlined. And then we've kind of come to this idea of at least once a month. If they're coming in every other week or every week for a few weeks, or, you know, for a few sessions, we don't necessarily do them every time. Some people do, some people really balk against that. So I don't, you know, really enforce it personally. They're usually handed it at the, you know, as they check in at the front desk. And then I've told them if they absolutely just don't want to do it, you know, they just don't have to fill it out. Because the front desk folks aren't going to know, you know, timelines, and I don't expect them to figure that all out. So most people are pretty good. They just fill it out as they're waiting. You know, not a huge deal, but there's you know, some people who just get tired of paperwork, I guess. And then as far as our clinical evaluation, we use the standard diagnostic assessment or the brief diagnostic assessment that is supported by the Department of Health, so or Human Services. In terms of engagement with individuals that might be interested in our services, we try to do the warm handoff. I mean, that's kind of one of our goals, is to have warm handoffs so that the primary care provider, whether it's the physician assistant, nurse practitioner, we have MTM pharmacists who also do a lot of referrals, and we have care coordinators within most of our clinics, and they also do a lot of referrals for us. But we will try to meet them, you know, bring a business card, sit down for a few minutes, even if they have, if the individual can stay past their regular appointment, and, you know, just do a one-on-one introduction, kind of introduce what we do, how we work, and see if they want to make an appointment at that time, or if they take the card and can call in the future. That's always an option as well. You know, you find if you get somebody to make an appointment before you leave them, it's more likely that they'll follow through. So, you know, kind of encourage that, but of course it's their choice in the end. But when people are on the fence, sometimes they just, it's helpful to just say, okay, I have a card that has a date and a time on it. Boy, that's, you know, at least I'll go 1 or 2 times kind of thing. We kind of can go that route too if they're still trying to decide. Or of course they always can call later if they would like to think about it. So we do a brief introduction to the service and let them tell their story a little bit too, that try to get that engagement. Sometimes it's 2-3 minutes. Sometimes if there's time, I'll do, you know, kind of a brief introduction type thing, 10 minutes, something like that, just to kind of see where they're at, what kind of, what is the next best step for them? Is it going to be meeting with me? Is it getting them connected to some resources in the community? Whatever it might be, that helps us figure out where the next steps go. Curbside consultation is also a strategy we use in terms of just connecting one-on-one with the primary care providers or their other providers, in terms of what might be helpful for them, whether it's resources, whether it's, hey, this person's been really having a hard time following their protocol for diabetes, or, you know, whatever it might be. Do you have any advice for us? They don't really want to meet a new person, or, you know, have time for other appointments. So sometimes we can just really give some thoughtful consideration to what might help the provider. And oftentimes that kind of comes down to, you guys will know, you know, using the idea of motivational interviewing to try to, you know, kind of encourage them to ask those kind of questions, or maybe even give them some handouts here. You know, if they have anxiety, here's some handouts, maybe that'll get them started. You know, so it's just really more of a consultation between the, like the provider, the medical provider, and then the behavioral health provider. We find those really to be quite helpful, and it really makes a nice team approach for the individuals. Let's see. Risk assessment, of course, we're available if a patient, when they're talking with their provider, has brought up any concerns about self-harm or harm to others. So we're, you know, it's nice to have that second or third set of eyes and ears and hands and whatever to, you know, help facilitate that, either make some decisions about what needs to happen next, or, you know, in terms of evaluation, or, you know, actually help get the process going and sit with them and, you know, kind of process through as they get a transportation to the hospital, things like that. I had somebody last week, for an example, where they said to the doctor, I'm just done, I can't do it anymore. And they thought, okay, we need a little more support. And it turned out they weren't suicidal per se. They were, you know, kind of dealing with some other emotional reactions, but we wanted to be clear and take a little more time with it. So that was a really helpful process, I think. And then referral, of course, people sometimes do need longer term therapy than what we're offering in the clinics, because we do try to think about doing brief, very focused therapies in the clinic setting. So if they do desire or feel like, you know, we feel like that would be appropriate, so like exposure therapy or, you know, something kind of more specific, then we can get them linked up to somebody where they feel more comfortable there. There may be age-specific things. Most of our clinicians work with adults primarily. Some of us down into, you know, adolescents, maybe into older children. But if we feel like they need, you know, something specific for younger or for family, or, you know, attachment issues or something where somebody really specialized should probably be involved, then we can get them connected. Obviously, we need a psychiatry referral. We can help facilitate that. Group therapy can be often very helpful also, so partial hospitalization or our intensive outpatient programs that we have here, and I think other systems also have some really nice programs as well. So we look into options there if they need grief and loss, DBT, you know, just kind of more, again, specialty things. We can help get them linked up to the services. And then community-based services if they need housing, if they need you know, help with their medical insurance, or any other kind of more social service kind of things. We can try to link them to the right people.
Okay.
Let's see. So yeah, really quickly, and I'm probably short on time here. We would like to be able to add psychiatry support specifically for our team, which we've had in the past, and that person unfortunately went away, and so now we've been kind of punting a little bit. So we would love to have the medical piece support. And then let's see, we're trying to come up with a specific informed consent that fits for our setting, I guess. We would like to continue to work on warm handoffs. We do, you know, you find the research will support that helps to decrease no-show rates. If people do meet you, they know who they're going to be meeting with. Even when you set an appointment down the road, you know, next week or 2 weeks, they at least have got a personal connection. So that seems to help with people following through, and that's kind of good. And then let's see, goal for access. My goal personally, and everybody's got kind of their own way, but I have it set up so I can connect with somebody within an hour that they're in the clinic. And so that's pretty good, even if it's just that 2 or 3 minute connection. We're trying to think about how we can utilize phone contacts as well. Population management, trying to figure out effective uses of Epic to help us with that. We've done this in the past with high ED users, for example, gotten lists or, you know, reports through Epic of who's been using the emergency department quite frequently, and then we figure out kind of what next steps might be helpful, what we can offer to them. And behavioral health is, in my experience, probably 75, 80, 85% of the time part of that plan. Whether they follow through or not, that's the second part of the story, but we like to at least offer it. And then we're thinking about how to engage our other associate members, working with doing maybe a diabetic group meeting with the pharmacist or the diabetic educator, so we can get a number of people in a room, have them ask questions, maybe get support from each other, but also can ask the medical side and also address some of the behavioral issues. Let's see, so that's about it. And we've had a lot of change in our administration and our clinical staff, so we're kind of working through that, and then focusing on continuing, like I said, those warm handoffs, curbside consultations, working on access, which of course is always people's, you know, on their minds and an important issue, and then population management, of course. So trying to figure out effective ways to use our time to help with that.
Okay, awesome. Thank you, Jess. I mean, there's much going on with patient-centric care and trying to figure out, especially those warm handoffs, I heard you say.
Yeah.
Does anyone have any questions about what they heard from Jess? What you can do is unmute yourself and just go ahead and ask your question. And we realize that there might not be questions at this point, and that's fine. As we continue to move forward, Jess will probably come back to you with some questions.
Sure, absolutely.
For those of you that have joined us after we started, please go ahead and type your name, organization, and email into the chat box for us. That's our form of attendance and connecting and knowing who's been with us. So please do that. As we move forward now, part of the ECHO process is really looking at more than just the didactic piece. We're going to move into the case presentation, and today we're going to have Fairview Mesaba Clinic Hibbing speak about a case presentation. The case presentations are really kind of the SBAR kind of what is the issue, or what is the concern, or what is the process that they have interest in regarding behavioral health and primary care and that integration. Also, what will happen is she's going to go ahead and share the case presentation. Then what we're going to do is we're going to ask clarifying questions. And after we do the clarifying questions, we'll go ahead and move into recommendations. And everyone is invited to participate. If you're a spoke or learner organization, you participate equally with your voice, as do our core hub subject matter experts. So everyone is welcome, because this is a all teach, all learn model. So please keep that in mind, and all are welcome to add some comments to this. So today we're going to welcome Sandra Christensen, who is going to do the case presentation. And as a reminder, when we do the case presentation, we do not use any patient identifying information, no PHI. So if at any time we hear PHI, we're going to stop and say, no, we have to stop that, okay? Because this is at a higher level for learning. So Sandra, please go ahead and share your case presentation with us this morning. You may need to unmute yourself.
There we go. Sorry about that. You guys are going to have to turn that down. We got other.
Yeah, somebody, okay.
Yep, we're good. Okay. All right, I'll go ahead and start. 47-year-old with stage 4 metastatic lung cancer with liver metastasis, history of anxiety and depression, currently homeless, and very poor support system. So that's the background. She was diagnosed in March of last year, being treated with antibiotics for a bronchial condition, and then she had a CT scan, and they found a lung mass and a mass on the liver. Moved from the Twin Cities up north here and established primary care at Fairview, and then her cancer care at Essentia Health, which kind of complicates things too. Her significant other had since thrown her out, and she had told me that she had been really verbally and emotionally abused since her diagnosis. Right now she's and really since I met her in August, she's been living in her car and living on a friend's couch, different friends. Her car is in need of repairs. She's been, she's got a dog that just had 4 puppies that she's placing, and that's been complicating things, trying to get housing. We have been working on housing since July. And she has a history of being homeless in the past. Let's see. I've been working with the local housing agency to assist her with options for housing. It's been very frustrating. Lots of phone calls with housing, not much response. I mean, we hound them many times a week. We're looking at an apartment now, and it's being pending inspection. We've applied for the patient crisis fund here to help with car repairs, which we're trying to get that in order too. The other thing too is we've scheduled her with our therapist because of her anxiety and depression, and that's just been really challenging with her infusion schedule, her fatigue, just the housing stuff. I mean, her basic needs aren't being met, so it's really hard to get her in to attend therapy sessions, but she really needs that. I also wanted to make a palliative care referral, but they won't see her because she's homeless. She needs to have a place to live. So another thing that I've done is I made a referral. We have a cancer care housing called Serenity Place, but because she does not obtain her infusion care here at Fairview, they won't take her in there. She was declined. We also have our community health care worker that has met with her, but that's complicated too because she doesn't have housing, but she had met with her at the housing office one time. So I guess, as far as questions, I think housing and just the frustration of it taking so long, And I'm new to the outpatient world. I'm from the inpatient, so this is all this stuff is new to me. So navigating this has been really challenging. So I'm not sure. I feel like she's in a pretty dire situation. I mean, she's got metastatic cancer, living in her car, and I don't feel like the supports that we have up here on the range are, you know, adequate meeting her needs. So that's pretty much it.
Okay, that's a lot happening. Let me see if I can do a quick summary of what I heard. So it sounds like we've got a patient that's stage 4 liver mets that has been homeless and is seeking primary care through Fairview system and cancer care through Essentia, which has negated her from getting Serenity Place coverage on where she gets her cancer care. Also, she's having chemotherapy, and she has a car that's in disrepair, and you've also tried to get her in for therapy, but she's got many barriers to being able to achieve both the chemotherapy and the therapy visits for her anxiety and depression. And palliative care is not able to engage with her because she's homeless and doesn't have a permanent residence. You've been working with housing to try to obtain housing for her, which would help stabilize the process a bit, but that has been a bit frustrating, to say the least, and new in trying to navigate that. And this is a dire situation. Is that a fair?
Right.
Okay. So what I'd like to do now is I'd like to ask our learner organizations or our spoke organizations, do you have clarifying questions for Sandra? Is there a question you'd like to ask? You might have to unmute yourself. I'm gonna stop sharing so I can see you all. Okay. So no questions from our spoke organization. Oh yes, go ahead.
I'm just wondering, has the patient's primary called the director of palliative care to discuss if there's other options?
Problem with you've got 2 audios on as well. Sandra?
No, I have not done that.
Okay.
That is something that could be done.
Okay. Other clarifying questions? We can go ahead and add the Core Hub subject matter experts in. Clarifying questions for Sandra's.
Hey, Sandra, this is Jeff Leichter from Sanford Health. I really, my heart goes out to you. This sounds pretty nightmarish. But I guess my question is, when we encounter a patient that just has a multitude of biopsychosocial problems, we tend to make assumptions from our lens about what's most important for this patient. And I'm just wondering if you were to speak for her, or have you asked her this question, is what does she want addressed first? What is she most motivated to work on? You know, to me, it would seem like housing, but I wouldn't be surprised if she said, these puppies are the most important thing to me. So I'm just wondering if she has prioritized your interventions for you.
Well, for sure, the housing, that has been her number one. She just feels like if she can get settled somewhere, then she can, you know, work on her issues in therapy, you know, just have her own space. I mean, she's been in these abusive relationships with men, and I think she's just ready to have her own space. So, and I think that is going to be the biggest thing for her. The puppies, I think she's placed all of them now. So, and that's been a barrier because I think had she not had an animal, she'd been in housing a lot sooner.
Other clarifying questions for Sandra?
This is Julie Erickson from Children's Minnesota, and I agree with Jeff that it's really a heartbreaking case. I think it's hard to start to pick apart where to start, because it's easy to get overwhelmed. And I share his initial thought, which was in the patient-centered care approach, sort of identifying, there's a whole list of things, of places to start, but both, I think, where the patient's energy is, but I think also helping to add in that lens or layer of, she's chosen a problem to focus on that is relatively out of her control, and it sounds like sort of unsolvable at the time. And so trying to think about what the other things that could help to leverage her health and mental health in the future. And so maybe I think the other main thing that you identified in the background was the poor support system. And, and I guess I just think how much that might help shift a lot of those other possible barriers. So she really does need probably some help with her mental health, because that's getting in the way of probably doing a lot of the other things. But so I don't know if there's ways to help then partner with, while we're working on, or we're sort of stuck on this one thing, what are the other things that we can have some control over? And again, I think my other clarifying question might be around what the resources are. It sounds like you're I guess I don't even know this for sure, the primary care provider. And are there behavioral health people in the clinic that could help even with really short-term brief interventions, or that could help her?
Yeah, and she has met with our therapist a couple of different times. And it's just challenging working around her infusion schedule, and then she's exhausted after. So it's not been as consistent as she would like and we would like, but we're doing our best. And I've gone over to her clinic where she gets infusion is kind of on the same campus here. So I have gone over there and provided her some support while she's getting her infusion, which is what, she really appreciates, having someone there that cares. So simple things like that have been really helpful for her.
Other clarifying questions for Sandra? While we're waiting, Sandra, a question something that you had surfaced is that she has her primary care with Fairview and her infusion for chemo with Essentia, and that negates her from having Serenity Place. Has there been a question of asking the patient about moving services to Fairview for chemo, or is that not available?
No, it's available. I suppose she could do that. It's just, she's got relationships with her chemo nurses. It's just, and I wouldn't, as a Fairview employee, want to be stealing away Essentia business either. It's just kind of we're a very small community, and you have to be careful not to step on toes. So.
Mm-hmm. I was just in the patient-centric view of if the patient could have more support services based on that opportunity. That's why I surfaced that as a clarifying.
Right.
Other clarifying questions that others have.
Hi, I'm Elise. I don't know if I'm popping up. I am wondering, does she have a case manager through her county that you could you could sort of make the process for an arms worker for her mental health?
I think if she doesn't have that. I don't think she wants that. She's enrolled with our program, so she probably doesn't need that extra support from the county. I am not sure there's anything they could offer that we're not already providing for her.
We tend to, at Entira, being kind of a smaller also family clinic, we do a lot of communication with county case managers. It's kind of just how we function with our care coordinators. So you may want to look into it.
It sounds like we're starting to move into recommendations. So I think it's time for us to go ahead and move there. So at this point, what we'd like to do is, what are recommendations or impressions based on the case presentation that we heard and the clarifying questions? What are some recommendations that that this group may offer to Sandra. And I'll ask the spoke organizations to go ahead and start first. What recommendations or impressions do you have that you would offer up to Sandra? And we could.
Hi, can you hear me?
Yep, go ahead. Hi, Jenny.
Hi, I'm Jenny from Open Door in Mankato. I really like what I can't see your name, but what the last person had said about, because it sounds like one of the issues is that she just does not have much of a support system. And so I think broadening the amount of people that she can go to for different things, whether that's a county case manager, I mean, whether that's ARMS, that sort of thing, I think expanding that support network is going to be really important.
Thank you. Other recommendations, impressions? I know, Sandra, you called out the little things make the difference. Are there other little things that others have tried or have made available that have made the difference that might be a recommendation to offer forward? We can go ahead and add in our Core Hub subject matter experts for recommendations as well.
Twyla in Ortonville. Are there any like cancer support groups in your area? Like I think of the county we live in, they do active fundraising to provide support and resources for individuals with cancer within our county that can help with some of the small things like groceries, transportation, those kind of things.
Yeah, she has been involved, limited with the support group as she feels she can go. You know, when she has so much fatigue that, you know, it's tough for her to get there, but she does reach out. So, and she's got great skills. She's a really great person. So she fits into that kind of, you know, so as she feels well, she does attend that stuff. And the Ascension nurses have, you know, gone to bat for her too and got her some resources as well. So.
Other recommendations or impressions?
Sandra, this is Jeff Leichter again. It feels a little bit silly for me to be asking you about questions about resources in your own community because I'm not up on the range, and I'm guessing you've probably thought about or talked about as many things as you have available. But one thing that we have over on the western side of the state are domestic violence shelters. You talked about that her significant other had been verbally and physically abusive. And sometimes the shelters actually have residential components. I know the one in Detroit Lakes does. So I'm wondering if you've explored that as a temporary housing alternative, which wouldn't be a poor fit given that she does have those struggles. That was just one suggestion, and I'm guessing you've thought about that. But the other thing was an impression or just a comment. I had a supervisor a million years ago when I was presenting a case that seemed hopeless. And what he told me was, which I've never forgotten, is just not to underestimate the therapeutic power of simply being present and witness to someone else's pain. And it may be that you've tried everything. I don't know. I'm guessing, given that you're a professional, you've probably thought about everything you could possibly think of. But even if you have and there's nothing left to do until something kind of breaks loose in this logjam, I appreciated your comment about how you said you'd gone over to her infusion site and sat with her. I really would not underestimate how therapeutic that can be. One of the things we offer as mental health professionals is hope, even when we can't deliver some product. And you have sent out a lifeline to her that you respect her dignity and that you respect her worth and that you want to help her. And I've had many patients over the years who were in hopeless situations that once those things kind of evened out, they commented back to me about how important it was that even though I couldn't fix, fix the situation, that they were just incredibly thankful for the emotional support. So I guess I would just, as a colleague, offer you the don't underestimate the power of what you're doing already comment.
I appreciate that. Thank you. And regarding the domestic violence shelter, it was the dog and the 4 puppies that prevented her from being able to do that as well. But yeah, and I think, just allowing her to vent her frustrations is helpful. I mean, so she calls a lot, and I connect with her a lot, and I think that it's made a difference. So even though I can't fix it, I don't have my wand to wave, but she's on the upside, she might be getting into an apartment this week. So I know, yay.
Okay. Other recommendations or impressions?
This is Julie Erickson again, and I think I just want to build off of the all the ideas around the sort of formal social supports for her is because just what you're saying about her ability to connect with people and the value of support and venting and relationships of, if there's a way to help her, it sounds like maybe she came up there with her significant other, so I don't know what her other personal supports are. She's got some friends she's staying on their couch, but I don't know if there's other ways to help either expand on or really sometimes, again, helping her to appreciate the supports and care and concern that people have for her, again, in that same sort of holding space of in the meantime and until she gets where she's trying to go, or if there's any other ideas that people might have about expanding that for her.
She actually brought up going to church, and so we've been kind of talking about that. She really wants to get involved with the church, and I have definitely been encouraging that, and I think that would be she could, get some good support, go to some groups. So I'm hoping that, once she gets settled, that she'll explore that too.
Okay. We've got time for one more recommendation or impression. Anything else to add? So, Gretchen, are you with us to kind of restate the recommendations that you heard? Okay, I'm going to go ahead and restate the final recommendations that I heard. So it sounds like one recommendation would be support systems to broaden services by potentially contacting county case managers, the arms worker. With that formal support services, I'll also kind of wrap in the connect and vent and potentially joining a church and such for support. Also, the cancer support groups available, if something is available, to explore options there. Resources in the area, the domestic violence shelter piece came up, and we understand with the puppies that was a no based on the animals. And that she's possibly getting an apartment this week. So if that falls through, potentially the domestic violence shelter could be an option for resources. and also the impression of please do not underestimate the presence of being present in a witness and a support to the pain that you see, and having the hope and the lifeline piece, and the respect for her dignity and her life and what she's going through. And then connecting on calls a lot. It sounds like being available to just let her vent is key. That is what I've gathered as we've been talking. Is there anything that recommendation-wise that I left out that you folks heard that I missed? Because I'd like to grab it. You can just go ahead and unmute yourself if that has happened. Okay. And this case is a prime example of the dire situations that so many of our patients face. Hearing today the didactic piece from Jessica about patient-centric care and the efforts that are happening to focus on the patient, the warm handoffs, etc. Hearing the case presentation today of one example of many folks across our state, of what they are dealing with. And now we've had a discussion, we've got some recommendations. Does anyone have any resource articles or any evidence documents that you would like to share for this session today that you'd like to send to me that I can share with everyone else that you can think of off the top of your head? Because we're very happy to be able to support continued learning and connection through any type of articles, etc. If you think of those after the fact, please let me know, and we will happily pass them on. What we're going to do is, after this, we'll send you out an evaluation by SurveyMonkey. Please go ahead and give us feedback, because that only helps us improve week after week. Also, we will be sending out the PowerPoint deck, the recommendations that we gathered, and if there's any articles or other things that surface, we will share those as well. Okay. Any final closing comments or thoughts? So our next session is going to be Thursday, December 12th. The Children's Minnesota will present the didactic, and Open Door Health Center will be our case presentation. So we're looking forward to our next session. Thank you all very much. It was very nice to see you all. We had many videos. I love it. If you have not put your name into the chat, please do that before you exit today, and reach out if you've got questions or information for us, and we look forward to seeing you on December 12th. Thank you so much.
Thank you.
Bye.
Oh, what are you doing?